So the fluocinolone acetonide implant is a non-erodible implant that is injected into the vitreous with a 25-gauge injector. The characteristic of the implant is a steady and continuous release of the drug into the vitreous that allows a long-term control of DME. So this is a clinical example of a 65-year-old female with type 2 diabetes and DME. She had multiple recurrences of DME, and she was injected with the dexamethasone. But then she was injected with the fluocinolone acetonide, and she had control of diabetic edema, macular edema, up to 2 years. And this is the graphic representation of the central macular thickness. You can see there are a lot of fluctuation before the implant, and then a steady control for 2 years with no recurrence of the edema. So our experience, we injected 120 eyes with the implant, and we had a follow-up up to 3 years. All the patients were not responsive to previous treatment and were pseudophakic due to Italian rules for reimbursement. All the patients were treated with previous drugs, anti-VEGF, steroid, or laser, and 10% of the eyes had received were vitrectomized. So we observed an increase and improvement in visual acuity. So this is a chart with the logMAR values. Higher values means worse vision. The patient with worse vision has the greatest improvement in the visual acuity, and also patients with the better visual acuity were able to maintain their good vision up to 3 years. And we observed no difference according to the duration of DME. So patients with chronic DME and those with not chronic DME responded well to the drug. The central macular thickness promptly reduced since the second month after the injection, and this improvement was maintained for all the follow-up up to 3 years. Some patients had a recurrence of DME, but this was successfully managed with the additional anti-VEGF. Notably, the interval between the fluocinolone acetonide implant and the anti-VEGF injection was very long, up to 1.5 years. One of the most important issues was the intraocular pressure control. So most of the patients did not experience safety issue with the implant, but some patients had an increase of intraocular pressure up to 30 or 40 millimeters mercury. We managed most of these patients with intraocular, with IOP lowering drugs, but 13 patients underwent glaucoma surgery after the injection. And we observed that the patients that had an increase of intraocular pressure after previous dexamethasone were those at major risk of glaucoma issue after the fluocinolone acetonide implant. So in conclusion, our experience shows that the fluocinolone acetonide implant was effective in the stabilization and improvement of visual acuity. We achieved less fluctuation of macular thickness and a reduction in the burden of the cost of the injection. But one of the most important things is patient selection to avoid safety issue with the drug. Thank you.